Uh, Good evening. Actually, we have now an interesting session that is sponsored by PUSEN company, which is talking about the new launch of 7.5 flexible ureteroscopy. It's the single-use flexible ureteroscopy. I'd like to welcome, we have two moderators for this session. Unfortunately, they are not here with us physically. We have Dr. Saeed Ben Hamri. He is very known to most of you that he is a consultant of endourology working in Saudi Arabia, and he is the chairman of endourology section of Saudi Urological Association, and he has a very long experience and publication in endourology. Welcome, Dr. Saeed Ben Hamri. And also we have Professor Wang from China. He's the Vice Director of Department of Urology, West China Hospital, Chuan University. He is also working in the field of endourology for many years with very long experience in that field. Are our moderators with us? Yeah. Thank you again for PUSEN for supporting this session. I'd like to check if Dr. Saeed and Dr. Wang is online with us. Okay. So actually, we'll feel free to have discussion and questions, and I think we may have some polls. So you have the mobile application of the conference. So there may be some quiz, so you can go and vote, and let's to see how it will work. So we'll start this session with, I'll give just a briefing about the updates in urolithiasis management. It's actually, if you look to the last 40, 50 years, it's a musical chair between different modalities. If you'll go back 40, 50 years ago, we have the only open surgery, the only tool in our hand. Then the PCNL came in the late 1970s or 80s, and then laparoscopy, and then back again to many PCNL and the flexible ureteroscopy. So it's like different time for each modality, but I think all of you agree with me that nowadays the open surgical pyelolithotomy has a very, very limited indication due to the advancement in the minimally invasive modalities and due to the technology advancement having different scopes. Even also laparoscopic pyelolithotomy, it has a limited rule in selected cases. And we can say that we are between three common modalities, which is the shockwave, lithotripsy, PCNL, and flexible ureteroscopy. And I believe also all of you, as many centers with high volumes in different areas in the world, showing a significant decline in the utilization of shockwave due to different stone size, patient anatomical variation. So a lot of factors decreasing the utilization of shockwave. And even we can see now in the European guidelines and in other guidelines that the PCNL is ideal for the large stone, and the retrograde intrarenal surgery is ideal for smaller stone than 2 centimeters. But the question is, does matter size? If we look to the PCNL, it has been proved in many publications, many centers, that using mini PCNL with a sheath 14 to 20, giving much better or same results as the standard PCNL with less complication as less side effect. This question could be applied also for flexible ureteroscopy. And this is, I will share with you some of the surveys, some of the experience. And we have today our experts that utilizing the 7.5. So please, if you have the mobile app, try to share your votes. So let's discuss together. Do you routinely dilate the ureter before retrograde intrarenal surgery? If you have your mobile app, you can just click if you are doing that, or we can do it by hand raise if you want. So usually in prax, we are dilating the ureter or not? Usually to dilate. So which type of dilatation we are using? You are doing double J stenting, you're doing optical dilatation, you do facial dilators, you are using balloon or any other dilator? Dr. Ahmad, which is modality you prefer? Excuse me? So you do dilatation before? Facial dilators. And then, so in one session, you are not putting double J stent and then patient comes later on. Dr. Mohsen, what do you think? Okay. No, if facial dilators. Dr. Ahmed Saad, do you do using this one? Previous.
Dilate the ureter.
Okay.
Only passing the rigid ureteroscope 8 French will allow the insertion of guide wire, and the access sheaths of 10 French will pass very easily after that.
Okay, so if I have Dr. Saeed with us online, can you share with us your routine prax? You are putting double J stent, Dr. Saeed Ben Hamri, or you go directly without dilatation? Dr.
Hello,
Saeed
good afternoon. Good afternoon, everyone. So glad to be among you. I go for double G stents. We don't do any dilatation anymore, and this is because of that the passive dilatation proved that it's more efficient than the active dilatation, especially for the lower and the middle ureter.
Okay, thank you. So actually, the point is, do you routinely use urethral access sheaths for the treatment of renal stone? Are here in the room, is routine, or you can go without? Yes, some doing it as a routine. Okay. 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 Okay, so actually for our delegates who are attending virtually, just what we have here in the room, that still we have diversity. Some are using the urethral access sheath on routine or not. Some are going without the access sheath based on the stone size. But the percent which we are using also is still variable, that which percent you are using the urethral access sheath. And this is the most important thing. What is the common urethral access sheath size that we are using in our routine practice? 10 to 12. So here in the room, majority using 10 to 12. If Dr. Wang here with us online, can you, Dr. Wang, share with us which size is routinely in China you are using for urethral access sheath?
Yes, routinely we use 12, 14.
12, 14.
Yes.
And usually you pre-stent the patient.
No.
So you go without dilatation with 12, 14 French.
Yeah, in our department, I think more than 90% without a pre-stand, we can put 12, 14 French sheets, no problem. But if we use 14, 16 French sheets, we always pre-stand.
Okay, so I believe that, to my information, in China, majority of our colleagues are using, the most common is 12, 14 to have better backflow, better visibility, and reducing the intrarenal pressure. Because I can share with our colleagues here in the room, if you are using 10, 12 with what size of the scope you are using. If you use 9 French, so you don't have enough backflow, and you are putting the kidney at risk of increasing the intrarenal pressure, and this will affect the visibility. So it's really challenging either to have large size, taking the risk of the trauma of the ureter and increasing the risk of complication, or you work with a smaller size with low visibility and low pressure. So in primary cases, I think we answered some of us. In primary cases, we may use it or not based on the stone size. But at this point, do you think the use of urethral access sheaths increase the complication rate? So do we have any experience with complication with urethral access sheath? And if yes, which complication we are worried about? Urethral injury, stricture, the hydronephrosis, infection, pain. So you face something relevant to urethral access sheath? Injury. So increasing, is it relevant to the size of the access sheath? Bigger the size, bigger the trauma? Dr. Saeed, can you give a comment about the size of the access sheath and the relative trauma? I think you have a previous experience or some publication about the injury of the ureter with the access sheath.
Yes, that's very true, because the first publication where the people were shocked about the ureteric injury due to access sheath was by Olivier Traxler, when he described 46.5% of the ureteral access sheath 12-14 caused an injury. But in his publication, the deep injury was about 10%. So the next 4 years later, they proved that the 10-12 has less injury by 20%, like abrasion. So the bottom line here, that 12-14 maybe has a failure to access the ureter, about 14 to 16%. But if you go to 10-12, you will have a failure to access that ureter by 10%, as we published a year ago.
Okay, thank you, Saeed, for clarification. Actually, I think from this question, this is help us to understand why the importance that we have a smaller size scope in our hand. I think there is a study is running now, run by IUA and EOLIS. They are trying to have a consensus about the utilization of flexible ureteroscopy. It's still under revision and for publication. It's 209 participants, and they reached to a 33 consensus statement. This I picked up some of them, which is JJ stent might be advisable if the scope or ureteral access sheath fail to enter the ureter. The semi-rigid URS could be routinely carried out prior to urethral access sheath instead of inserting the double J stent to evaluate the ureter and to dilate at the same time. And utilization of access sheath is preferable, but if smaller stone, as our colleagues here mentioned, urethral access sheath not be a favorable one. Another survey done also with the professional endourologists at different levels worldwide that showed 76% are routinely using the urethral access sheath for the treatment of kidney stones. And worldwide, we have diversity about the size, but majority are using 12-14 access sheaths. This allow better visibility and better backflow and reducing the intrarenal pressure. And 42% use the urethral access sheath in primary ureteroscopy. 90% believe that double J stent insertion is not mandatory prior to urethral access sheath insertion. And 79% think the use of urethral access sheath doesn't increase the post-operative complication rate. And the most common complication has been found is the stricture and pain. So again, the smaller, the better. The answer, I think, it's yes, because if we have a smaller size, so we will have the same quality, same visibility, same quality of the vision, and we have better irrigation, and we have good backflow, reducing the intrarenal pressure. So having a smaller size scope, it really matters, and it can help that decrease the need of pre-stenting and reduce the use of urethral access or reduce the size of access if you need it. And in sequence, it will reduce the complication, and for sure, it will reduce the staged procedure that you pre-stent and then you do the procedure and then remove the stent and even the utilization of access. So for sure, you are reducing the cost and the long journey of the patient for staged procedure. So I think it's a good chance that we have all in our hand now, the smaller size flexible scope, and I think also it will open the window for pediatric utilization. And I will stop here, and I will be happy to introduce Dr. Saeed Ben Hamri. He will give us his experience about the 7.5 French flexible ureteroscopy in pediatric urology. Welcome, Dr. Saeed.
Thank you very much. I'm so glad to present, to be among those people who are launching the first 7.5 scope from PUSEN on the world. I'm so happy to be among my colleagues, renowned surgeons, consultants. Thank you, Dr. Yasser Farhat, inviting me. So I will just expose what we can do with the 7.5 in a pediatric patient. These are my declaration, and all videos, images you're gonna see are they were consented from the patient and then in my center. As you know, all that most of the companies, they compete for size and vision. If you notice, 2008, the Olympus was a so big 9.9 French. The competitor stores brought 8.4 with the same quality of vision that kept the conventional scope 8.4 from P5, or even the P7, as you're gonna see, is only 8 French. So this will tell you that these companies are trying to compete on the vision and the size. The Olympus P5 was about 8 French in the shaft. So imagine that you're working with a scope, it's almost a double G stent 8 French. Some of the disposable brought 8.6. So they're bringing these instruments to serving more your purposes of treating the patient. Wolf as well, they brought the BOA. The BOA is the smallest axis, smallest digital endoscope, goes into 9.5, 11.5. This kind of access sheet is made by Cook and by Geotech in the market, and some Chinese companies. If you go with the 7.5, as you can see here in the slide, do you hear me, right? Dr. Yasser, do you hear me?
Yes, Dr. Saeed, we hear you clearly.
Okay, so I will just go to this slide. If you could see clearly that the semi-rigid from Olympus, the tip is 6.4 and the shaft is 7.8. If you compare by your simple vision that the 7.5 of PUSEN is less than that. So is the PUSEN giving us something less than 7.5, or Olympus is lying about their sizes? So the point here that this scope 7.5 is not through 7.5. It must be less than that, because the image is clear. The working channel kept as a 3.6, and the deflection is kept perfect as the conventional or the digital. We know all that one of the characteristic of the conventional or digital scopes is the double deflection. We call it double deflection because you can swim, you can go to any calyx that you want inside the kidney. And for that, when the first generation of PUSEN 9.9 French or 9.2 French was able to do the same, despite the size of that scope. With this scope 7.5, this is in a small kidney for a patient 18 months old. You can imagine very well the size of the kidney in that baby. How could that flexible endoscope swim and goes to the lower calyx, which is something that we could not, we never imagined that it could happen with these small scopes with the perfect deflection. The 9.5 French from PUSEN was able to go to lower calyx with a good deflection, and we could treat those big stones in the lower calyx without having the fear to break the stone. So we know all that the big truck is not easy to deflect and goes and driving, except these small cars. So the same principle, when you go smaller by the size, you go free in the movement, you go free in the deflection. This is a nice paper, 2006, by Singh and group of New York, where they published a stone size 14 millimeter. The age of a group is 4 to 15 years old, and they use an Excel sheet 1214. So some people will say, how could you put that Excel sheet 1214 in a small baby 4 years old? This report came with no mention of the complication. So the people where they used 14 years ago using the 1214, and we are not saying that. We don't say use the 1214 and a small baby 4, 5, 6 olds. You have 5, 6 years old. You have these new instruments, or we call it instruments 3 years ago or 4 years ago. You can use the P5, P7, 8.4. P7 is the 8 French. You can go down with the Excel sheet to 1214. You could see clearly how are these ureters from 2 years old baby, 5 years old baby, 7 years old boy, and 9 years old. So the message here, as good as you can, go with your instrument, whether the scope or whether the Excel sheet. And if you don't use an Excel sheet, there is no problem. One of the challenging cases is the retrograde interventional surgeries for small babies. If you have a perfect scope, you can go for a 2 centimeter stone with no problem, good laser, good irrigation. If you are using 8 French scope with the Excel sheet 10-12, you could have at least 2 French for better irrigation, better backflow. This is another patient. She's a 6 years old girl, 14 millimeter stone. We use a digital Flex XC 8.4. The Excel sheet was 1113, and you could clearly that you did this job in 30 minutes. This is again a 13 years old girl, 2.5 centimeter. We used a laser with a dusting method. Wise irrigation. The Excel sheet was 1113. The endoscope was 8.7. So you got about 2 to 3 French to have these dust out and more irrigation, more flow up, and better vision. You could do with these small scopes bilateral same session ureteroscopies. This is an 8 years boy, 8 millimeter lower uteric stone, or 2 centimeter in the renal pelvis. You could go for bilateral uteroscopy in a 4 years old if you have these small instruments, and you achieve more in such patient by developing or adapting your instrument to your patients. This is a patient with a cystine stone, had 4 PCNL failed, 3 uteroscopies, recurrent cystine. We had an agreement with his family. As you could see the scan pre-op and post-op that he has a stage therapy and no more insult to his kidney due to multiple PCNL. So the smaller scopes gives us a space to keep those kind of patients very specified, very specific condition that we keep the kidney function. As you know, most of those patients go for the kidney failure because of multiple procedure. And we achieve something with those kind of patients due to small size of the scope. And this is what I have tweeted like 2 weeks ago, or maybe a month ago. This is 11 years old. This injury caused because we want to use a 9 French. And fortunately, 4 weeks later, this is his ureter, healed very well. The message here, through these injuries reported 46, 70%, but what is the stricture rate? The stricture rate is less than 0.1%, or in the most of the publication 1%, due to using of a small instrument and knowing what is the most important factor. As you know, all that the strictures caused by multifactorial. What about the active dilatation? What about the impacted stone? What about perforation? What about laser thermal injury? So the message here that with the big scopes, we cause that injury, but fortunately, that was healed very well. But this one will not prevent us from using a small size of the scope. That's why PUSEN came with a 7.5. This is an 18-month-old baby with a 9mm stone in the renal pelvis. You could see clearly that the small caliber of the ureter, that the PUSEN swims easily inside this kidney, as you could see here in the video in the middle, and then hit that stone with the dusting method. With no problem, and a good deflection into lower pole of that small kidney. And of course, we used an access sheet 9.5, 11.5 to just decrease the pressure in that small kidney. You cannot imagine how much pressure you put if you don't use an access sheet or you use a big caliber of the scope. Imagine that you put a 9.5 scope inside this ureter. I would hardly believe that you could achieve the same thing as you could achieve it with 7.5. So the take-home message is here that the anatomy and the material concept should be taken into consideration for every endourologist wants to work. Go smaller, because size does matter in urology. It's the same as the PCNL. If you have a 30 French, you have a 24 French, you have a 14. So in urology, retrograde interrenal surgery, you have to have all these sizes to achieve more with your patient. Pre-stenting in the children proved in many literature that it caused less complication and higher success rate, but it doesn't mean that you have to pre-stent all the patient. If you have a 7.5, go easily, no force. If you have a force, put a stent and come again. It's a very low morbid procedure, but you have to understand that the material does a very big, large portion in caring of these patients. And again, I always say that every French counts, especially in endourology. Thank you very much.
Thank you, Saeed. It's really very interesting. Can you stay with us, please, till the end of the session, because we have many colleagues here are presenting, but I can just conclude with you that your expectation of larger access sheath, it will decline significantly in the next few years with smaller scopes?
True. It's not only, Dr. Yasser, the smaller scope. It's because we used to have a big access sheet because of the scope is big. And more than that, we used to mask it. But with the laser that you intend to dust, you don't need to mask it. So why do you need a larger size of scope? So when you go smaller, all the instruments around you will help you to help to achieve more and more, especially the laser and the size of the scope.
Yeah, I will enforce also your comment that every French matter, that the smaller that we have in our hand, the less complication and the more safety for our patient.
True.
Is it okay? Okay. Thank you, Saeed, and stay with us. We will move now to Professor Wang from China. As I mentioned before, he is a very well-known in center of China, West China Hospital. He is the Vice Director of Department of Urology, Sichuan University. He will give us his experience about urethral reconstruction and the disposable flexible ureteroscopy. Welcome, Professor Wang.
Thank you very much, Professor Yasser. It's my great honor.
It's my great honor to join this meeting. Especially, I'm thanked very much to treat the ureter structure. In our experience, most part of the ureter structure can be treated with reconstruction surgery. Why we pay so much attention to the ureter structure is because the instance of the structure following the ureteroscopy is high, and the instance of ureter structure after the OB/GYN surgery also very high. So this is why the worldwide, the urology doctor more and more pay attention to the ureter structure. We all know the treatment strategy of ureter structure is based on the position and the length of the ureter structure. And the ureter have the anatomy special is the blood supply vessel is relatively same. So this is we need to pay attention to when we do the surgery. As in our experience, the reconstructive strategy for a proximal ureter is a little bit different from other centers. We use the UPGOs as cases to talk our strategies. If we review the history, at the beginning we treat the UPGO, we use the lung dismembered operation, and someone use a YV peloplasty. And when Anderson and Hennis use the open dismember peloplasty, then we do more and more dismember surgery. But which is better, still many controversial. And now we use the laparoscope and even robotic to do this kind of surgery. But we are a little bit confused. Saying is when we enter the minimal invasive time, but we encounter more patients with a recurrent structure and urine leak after the ureter reconstruction, which is transferred from the other center to us. So we need to rethink about it is reasonable to cut the renal pelvis manually. This is one of our cases. This is before the surgery, we can say typical OB UPGO. And this is the CT scan after the surgery. You can see the hydronephrosis is same like the before the surgery. If we compare this imaging before and after the surgery, you can see it's not a big difference. But this patient after the surgery, they pass out so many big stones by themselves, which tell us non-dismembered surgery also can give us good result. They can pass out so many big stones, they also can pass out the urine freely. So this member tell us that dismember is not maybe not good choice for us. Another reason we be told why we dismember is our teacher told us that dismember surgery is more good for peristalsis. Is that true? We see more detail when we use the robotic surgery. This is one cases we open because we do not dismember the ureter. We see actually the peristaltic way is very good. Not like our teacher told us the peristaltic way is interrupted at the structure area. You can see the way come and go freely to the lower part, distal part of the ureter. So this video told us actually in the UPGO's patients, the nerve transfer is good. If we cut this part, actually we interrupt the nerve transfer. So we think if we dismember the pelvoplasty, the regeneration of nerve is not good. So we think, especially for the ureter, the blood supply is same, the nerve is good. We need to rethink about how to do the ureter reconstruction. We think we should use a basic example of plastic surgery, which is we try to minimize the disturbance of the blood supply and full protect and utilize all the soft tissue. And how to do that? This is one cases we use. You can see in this very short ureter structure, we did not cut the ureter. We just use the sutures up and distal and reconstruct the plate of the ureter. You can see just one suture, you can see the magic effect for the ureter plate. Then we close the ureter. This is for very short ureter structure. But if for the structure longer than 5 millimeter, how we do that? We use the buccal. How to use the buccal? We use the onlay technique. That is the key technique, because if you use the tuber technique, the success rate is very low. You should use the only technique. How to use the only technique? Just like this. This is one open surgery. We even use some skull skin-free graft to reconstructing this long ureter structure. You can see this is 5 centimeter ureter structure. And after this surgery, we use the ureteroscopy to check the effect of this surgery. We can see the mucosa is very, very good. When even we use a skull skin-free graft. And now we use the robotic. We also can use some special technique to tell us the exactly structure area. Just use this special technique, the firefly. If we inject a firefly through the ureter and under the robotic, we can see where is the structure area, so we can cut the ureter just be upper or below the structure area, and we do not dismember the ureter, just cut it along the ureter. You can see these cases, we just cut through the ureter. Then we go through the structure area. This is structure area. You can see after we cut the structure area, the urine is come out. You can see, okay. Okay. Then we cut it. Then the first step, we still use the suture to reconstruct the ureter plate. Just two suture. You can see the magic effect. You can see the other suture on the other side. You can see this suture. You can see the ureter plate become bigger. After that, we put the buccal free graft, and after we suture it, use the only technique. After and put the stent, and this is what it looks like after we finish the buccal only technique. But this is not the end. We need to think about how to make it regeneration. So we use the flap of the other tissues to cover it, to make it get good blood supply. Then this is the end of the surgery. So this is what we do for this long ureter structure. But sometimes the local condition is too poor. We cannot use free graft. What we do in this kind of condition, we use the auto-transplantation or intestinal ureter replaced. And the cut edge of the intestinal replacement is now we even can use the appendical ureter replacement. Yes, and how to use it? We still prefer use the only technique. of use appendix urethral replacement. We do not like this kind of technique because this kind of technique sometimes the chamber of the appendix is not so good. But if you use the only technique, most situation you can guarantee the chamber of the reconstructed area is good. So in our center, our experience told us if for UPGO's patients, most cases we use a lung dismember surgery. And for the proximal urethral structure, if it is shorter than 1 centimeter, we try to reconstruct the urethral plate. If longer than 1 centimeter, we use the mucosa. If it is too long, we need to think about renal transplantation or use the intestinal, especially appendix reconstruction. And thank you very much for the invitement of my good friend Said, and also thank you very much the PUSEN company's support to make the chance we can say so many my good friends online, and wish you have your department develop very good and quickly, and we also look forward to see all our good friends in China. Thank you very much.
Thank you, Dr. Wang. It's really interesting topic. Can you stay with us till the end of the session, because now we need to have sharing experience of our colleagues who are using the 7.5 flexible ureteroscopy, the new one, and we will run through experts from different countries. We'll start with the UAE with our colleague, Dr. Rashikesh Bandaya. He is a consultant urology from Abu Dhabi. He is not with us physically today, but we have his case recorded. Can we play it? Dr. Bandaya is available online? Okay, so he's available online also if any questions.
Hello everybody, greetings from Dr. Rishikesh Pandya. I hope the world is safe, all of you are safe and healthy in this COVID times. And at this point of time, considering the meeting that we are in, I am glad that I am going to speak on the opportunity, to speak on the 7.5 French flexible ureteroscope. As you see, the title is Thin Scope Wide Access. It is very self-explanatory. And we have all used 9 French scopes earlier, and let us see how 7.5 in my hands. So this is a case of 34-year-old gentleman who presented with right renal colic. His stone size approximately being in 2 dimensions, 3.5 centimeters by 2.5 centimeters, predominantly being the renal pelvic stone. So this is the image seen on the fluoroscope just prior to the surgery. And there are small lower calaceal satellite stones as well. And as you see, as we move ahead in the surgery, we have got a significant and a good clearance at the end of the procedure, which if you see here, it is 8:40 time, and here it is 10:24. So it is roughly around 1 hour, 40 minutes, which we took to complete the stone. And so this was not a pre-stented patient. The first surgery was done on 10 February 2021. The surgical time, a little more than 90 minutes. Laser time was 16 minutes. I do optical dilatation for these patients by using rigid ureteroscopes, 6 French followed by 9.8 French. So I can get an access of 12 to 14 access sheath. Obviously, the scope here used was 7.5 French PUSEN flexible ureteroscope. I use the dusting mode, as you can see here. This is the screen of the Quanta laser, and I could achieve a significant amount of clearance in the very first attempt. This is a more close-up view of the fluoroscope pre-op, and this being the post-op during the insertion of the stent. And as you can see, there is some dusty material which might be residual of nature, and pending to come out maybe around stent. So 29 days post-operatively, when the check X-ray was done, this patient had that dusty material collected in the mid-ureter in the form of a Steinstrass, as I am pointing it out on the with the arrow. So 33 days later, that is few days after this X-ray, second stage procedure was done. Rigid ureteroscopy was done. The time taken was 20 minutes. Laser was 4 minutes. Complete stone extraction, Steinstrass was removed with basket and washes, and complete stone clearance was achieved, and a restenting was done. After the second procedure, patient went to the home country, which was India, and on return, we did a fresh X-ray as seen on the left side. That was 46th day after the second stage procedure. The timings I am mentioning specifically because we learned something out of it, especially for little larger stones. So as you see, there is no residual stone or no residual stone material. So on 52nd day after the second stage procedure, DJ stent removal using flexible cystoscope was done on OPD basis under local anesthesia. So certain comments and certain points why the thin scope, wide access, and all this modern technology has improved is because 7.5 scope, the thin scope, 12 by 14 sheath, the wide sheath. So why cannot it compete effectively with the ultra mini or micro PCNL? I'm sure very soon the world of urology will favor this access as compared to the micro PCNL or ultra mini PCNL, where the instruments are very fragile. So in this case, the patient had two procedures which were daycare procedures, one outpatient procedure for the DJ removal, and time away from work was just 3 days. Complete stone clearance was achieved almost for a partial stag-on. First procedure, as I said, little more than 90 minutes. Second procedure, actually a little less than 20 minutes. So thin scope, wide access. So small scope, wide access, you need good laser, you need good irrigation so that the dust and the material can be washed out simultaneously. That is the idea of having the thin scope and the wide access. So the intrarenal pressures remain low. And there is no harm leaving the stent for longer time. This is what we learned from this patient going to the home country, coming back a little late, and he was comfortable. He had his personal life back home. So there is no harm keeping the stent for a longer time. It makes sense in such kind of larger stones. So, and definitely we should be counseling the patient for multi-stage procedures for clearance. So I'm sure at the end of this small presentation about the case, thin scope, wide access is the new way to go. And I'm glad that PUSEN is providing us the 7.5 small thin scope. Thank you very much for the patient listening. Have a healthy, safe life.
Thank you, Rashkesh. We will move to the next presenter sharing with us his experience about 7.5 French flexible ureteroscopy. He is Dr. Hussein Mohammed Aberi from Saudi Arabia. He is the consultant urology at Security Force Hospital. But before going to Dr. Hussein, I think all of us noticed that Dr. Rashkesh didn't get the benefit to use smaller access sheath, and he kept using 12-14. Maybe this returned to the larger size of the stone in his selection, 3.5 centimeter. So I think this can be discussed at the end. We'll share it with you. Dr. Hussein, are you there?
Bismillah ar-Rahman ar-Rahim. Today, yes. I'd like to share with you this case I'm from Security Forces Hospital from Saudi Arabia. This patient is Rimas. She's 16 years old, female. She's known case of cystine stone with past surgical history of left PCNL about 2 years back, and with history of multiple bilateral retrograde intrarenal surgery. And for the time being, when she was presented laterally, she's on medical management. So this time she presented to our clinic with left renal colic And when we saw her in the clinic, she was showing UTI. The urinalysis was showing the pH of the urine was 6. She was on medication, and also there was bacteria in the urine. With culture was positive for E. coli with multisensitive. CBC was within normal, and the creatinine was a little bit elevated, and this is known since before with her. At that time in the clinic, we diagnosed her to have left renal stones by CT, as we see here. It was the radiolucent stone. So as we see here, this is the axial cut for the CT for this patient, showing this is the stone. This first stone was in the middle calyx, and this is about two other stones in the lower calyx. There was no stones in the ureter, or no any stones in the other kidney. And this is the coronal section, showing that this is the two stones, and also there is third stone in the rubber ball also. So after that, we treat the patient with oral antibiotic, and repeated urine culture came to be negative. And we book her for the left flexible URS as day surgery case. And in the OR, the day of the OR, we consent her and we prepare her for surgery, and we put her in the lifting position. We start with her with cystoscopy and retrograde retrograde study. And in the retrograde study, showing we start from the nephrogram with inserting the guide wire, and then we also the ureteric catheter. Then showing here the ureter was a little bit dilated, and the whole ureter. We check the whole ureter, and we find that there is a filling defect in the distal ureter. So there was a stone comes down from the kidney stones. It was not seen in the CT. So we decided to do for her first semi-rigid at the same setting, semi-rigid URS and laser fragmentation of the stone, and with basketing. Stone in the ureter was cleared, and then we advanced the urethral access sheath over the guide wire, and the guide were taken out, so that we left with access sheath size 10-12, use size 10-12 access sheath, and then we advanced the flexible 7.5 French PUSEN ureteroscope, and we start to change the position to the Trendelenburg Lithium position. And we did nephroscopy, and we find there was two stones in the lower pool, and we localized them to the upper pool with basket size 1.9 French, and then we use dusting technique for fragmentation. And the Trendelenburg position, it helps us to keep the stone steady and during the dusting. All stone fragmented. Some fragments was taken out by the basket, and then we left in digestent. It was left with thread, and then which was removed later on after 4 days in the clinic. So how was this scope? Actually, we find this scope, this is the 7.5 scope, where the vision and deflection was and manipulation was good. Actually, it's comparable with the previous scope and with other larger scope. And at the same time, while it's smaller in the diameter, but the working channel is the same size, 3.6 French. So it's same as the larger scope. This one, it will improve the drainage due to the smaller diameter of the scope. So it will improve the urine out, or the fluid or the gaseous coming out through the access sheath. This one will lead to decrease intrarenal pressure, which is, by the way, it will decrease the post-op infection and post-op fever. Or the risk of post-op fever and post-op infection, which was proven since before, but for this scope, it's not proven yet. As we see here, this is the scope, and this is the large, or this is the digistent size 7.7 French, and this is our scope, which is comparable or it's a little bit bigger than the digistent. So this scope, we can use smaller ureter access sheath, or even you can use the scope directly without access sheath. And I think the scope is promising for pediatric age group and for the narrow ureter. Thank you for listening to our presentation.
Thank you, Dr. Hussein. The next speaker is Dr. Ahmed Saad from United Arab Emirates. He will share with us his experience about 7.5. Dr. Ahmed Saad, he's a well-known expert in endourology, especially flexible ureteroscopy. Welcome, Dr. Ahmed.
Thank you. Actually, I will present one case report for a 74 years old lady who came to me with bilateral renal stone, large renal stone. And she had past history of very complicated surgeries on both sides, PUSEN and open surgery. So I discussed with her the options for the treatment, and I gave her the option of doing multiple staged bilateral RIRS. Fortunately, that I used PUSEN 7.5 French all the sessions which I did with her. And we can see now the movie and see. This is a case report of Mrs. Tamina. She had recurrent UTI and recently right lung pain. She's a 74 years old lady with overweight, 35% BMI, non-bilateral large renal stones, and she had many comorbidities. On ascending ureterography, as we saw, there is a flower vase deformity of the kidney. And here, we're using the flexible ureteroscope, 7.5 French. The first session on the right side was done with a lasing at 0.5 joule, 10 hertz, and 5 watts in a session which took about 4 hours. And the first session, almost 50% of the stone was dusted and fragmented with the removal of most of the fragments. And after that, the double J stent was inserted. And after 1 week, the second session on the same side was done for the remain of the stone. You can see here the healing power of the transitional epithelium, lining of the kidney, and these are the remains of the stone. Also, the same lasing power. The second half of the stone was done. Even in the narrow parts and most sticky parts of the stone, which is the lateral anterior part. Patiently and cautiously, the stone was dusted and fragmented.
About the maneuverability of the scope.
The remaining part of the stone.
It was same as the large one?
Character that the maneuverability is very good.
Okay.
And I can go anywhere inside the kidney, even the most difficult part of it, the
Can see here
lateral
the
and the anterior
large
calyces.
parts broken from the stone,
Okay.
which is dusted very well, with good vision and good brightness of light.
What size of access sheets you are using in this case?
I use 10, 35 centimeter,
10, 12.
10, 12,
Ah.
35 centimeter
Okay.
lateral axis.
And this was the end result. The most of the stone is removed. With a compound calyx in the lower part of the right kidney seen after removing all the fragments. A double J stent is inserted again, and then after 1 week, I started to do the left side, and this was the stone in the left side. This is the velvet part of the stone and the branches inside extending to the calyces of the lower moiety of the kidney. The same laser fiber, but here I started with 0.5 and then increased the energy to 0.8. After first session, I removed almost half the stone and put double J. On the second session, 1 week later, I did the remain of the stone on the left side. Here I increased the power and energy to 0.8 from the start.
So total for the bilateral, how many sessions?
4 sessions.
4 sessions.
Each
This
session
part of the
durated
stone
about
was
4
a
hours.
little bit
Okay.
of high matrix content. Most of the stone become dusted and fragmented with removal of the fragments.
So any
And
special
before ending the
recommendation?
session, I usually
is
see
still something
under
you
the
want to show
CR
in the video,
if
or we
any
can
remaining
move?
parts.
Actually, I want to show the
There was a
maneuverability
hidden
of the scope
lateral.
at the end
Okay.
with the residual fragment in the lateral calyx.
Okay.
Anterior calyx.
And then the post endoscopy X-ray,
Could
see how
maneuver
much
this
the
area
residual
properly
and
with the
whether
seven
residual fragments are significant or not for such patient.
Okay.
A very
and
difficult
dusted
calyx.
with the same power of laser. Here, this is in a very difficult position. I can see the stone properly and laser fragment. And this is the end result, X-ray after removal of the double J stents.
You see,
These
these
residual
are the
fragments
residual
are
fragments.
questionable area, whether to have significance or not. And actually, I prefer the clinical definition of significance of these fragments. Actually, the flexible disposable ureteroscopes, mainly PUSEN scope, allowed properly to do a repeat procedure with high efficiency, easier maneuverability, and least expenses. But the question is, does 7-point French scope have advantages over 9 French scope? The answer is big yes.
Thank you, Dr. Ahmed. But let me to ask why yes, in such a case specifically, why you have this impression?
As we can see in the movie here, in spite of the recurrent infections, matrix nature of the stone,
Yeah.
the clarity of vision itself is very good. because of the decrease in the intrarenal pressure and drainage of irrigant and wash out of this turbidity through the normal urethral access sheath I used.
Yeah.
So actually, it helped much to proceed and to hurry up and fasten the procedure uh, than the other scope.
Okay, thank you, Dr. Ahmed. We'll move to from UAE to Kuwait. Dr. Hussein Al Anezi, he's a very known consultant, endourologist. He's Secretary General of the Kuwait Urological Association. He's always supporting and participating in our activity. Dr. Hussein, are you there?
Yes, I'm here.
So,
It's a great honor to participate, and thank you for the invitation. I'm from Kuwait, and my case for today is about this 52-year-old male who's known case of hypertension. He's been complaining of right line pain, recurrent attacks for a few years, and he's been avoiding surgery due to fear of complications, trying all kinds of herbal medications. But apparently, because of this complex right renal calical system and average Hounsfield unit of 1,250, this stone was not going anywhere without surgery. So my option to him was flexible ureteroscopy, and because this allowed us to do his stone with the least possible complications. And also I explained to him that this might take also 2 sessions instead of 1 session. We started with a cystoscopy, and cystoscopy showed, as we saw, that his urethral orifice was a little bit tight. So we proceeded with retrograde study, which showed that the stone was situated in the lower calyx and the lower infundibulum, and causing obstruction with no much space around it. So I started, because of the tight urethral orifice and the tight lower ureter, I started by inspection and dilatation of the lower ureter using semi-rigid ureteroscope, which took only a couple of minutes and allowed us to make sure that there's nothing wrong with the lower ureter. Then I backloaded the 7.5 disposable flexible ureteroscope over a guide wire up to the kidney without using a safety guide wire. Then laser lithotripsy was started. I used the dusting mode, and as we can see here in the fluoroscopy images, that like serial fragmentation was done all around the stone until really the stone was at the end gone. Using the slim flexible ureteroscope allowed us to actually navigate all around the stone and to engage the scope in very tight spaces in order to fragment the stone from here and there. As we can see that in the start of the procedure, vision was not that much good because of the limited space and because of the little bit of bleeding from the impacted stone at the infundibulum. However, as space was made by fragmenting the stone, the vision was much better, and this allowed us at the end to reach a popcorning effect. And at the end, as we can see, most of the stone was actually turned into dust. And then I was able to actually navigate the whole system in order to make sure that there's no residual fragments. And this led us to this final image. So we moved from this from the start with a large stone situated in the infundibulum of the lower calyx into a very clear retrograde image with no filling defect and no residual stones endoscopically and fluoroscopically. So the advantages of the 7.5 flexible disposable ureteroscope, in my experience, that it's being slim is the greatest advantage, which reduced the chance of access failure in non-stented ureters. Using the larger disposable scopes, I always tell my patients that there is a chance of failing to access and the chance that we put a stent and come back after 2 weeks. However, using the 7.5 flexible disposable ureteroscope, this is less of a risk, and this is less of an issue with the patients. The slim scope also allowed us to navigate the system in narrow spaces so we can break the stone from here and there and move on as we go when treating larger stones. Also, I think the slim scope gave us less intrapelvic pressure when compared to using larger scopes, and that probably allowed us to finish this larger stone in one go. The lightweight of the scope gave no fatigue to us during doing the surgery, so we finished the stone without actually feeling tired at the end of the procedure. Being a disposable scope, there was no fear of scope damage, so I was able to actually engage the stone all around, or the scope all around the stone, with moving the laser fiber in and out without fearing that the scope will be damaged at the end, because it's a disposable scope. Enhanced vision in comparison to slim fiber optic scopes was another advantage, because slim fiber optic flexible ureteroscopes were my second option if the 7.5 flexible disposable scope was not ready. Thank you very much for your attention.
Thank you, Hussein. We'll move, because we are short little bit of time, to Turkey. We have Dr. Muhammad Merkemek. Dr. Muhammad will share with us his experience about using a 7.5 single-use ureteroscopy. Welcome, Dr. Muhammad.
Thank you very much.
Dear Chairman and dear colleagues, I am Dr. Mehmet Mercimek. I'm a urologist at the Department of Urology, the Hospital Samsun, Turkey. In this presentation, I'm going to talk about our first patient whose kidney stones were treated by using a 7.5 Frank PUSEN flexible ureteroscope. If you look at the demographic findings of the patient, 21 years old, male, admitted to the emergency department with left lung pain and nausea for 3 days. The medical history revealed no additional diseases, no medication, but he has a shockwave lithotripsy treatment at the age of 6 on the left side. On the physical examination, the positive finding was only tenderness on the left upper back. The urine analysis revealed microscopic hematuria, and ultrasonography revealed 2 kidney stones and mild hydronephrosis on the left side. A non-contrasted CT was performed to obtain detailed information about stone location, stone size, and the density. Considering this patient, retrograde intrarenal surgery and PCNL have comparable outcomes to achieve completely stone-free status after single session. But for this patient, the other procedures such as open and laparoscopic surgery may not be suitable. Apart from our initial patient, in patients with complex renal stones, it should be kept in mind that laparoscopic surgery with a combination with new flexible devices may facilitate to increase stone-free rate. And then we look at our initial patient. Again, our final decision was retrograde intrarenal surgery. In this slide, I will show you our procedure briefly. That long in 3 minutes. First of all, we inserted a 12 French ureteral access sheet, and then go through into the renal calyx, and upper pole of the left renal kidney were controlled in order to another pathologies. And then the stones were seen in the lower pole. And these stones were moved to upper pole calyxes by using basket. As you've seen on the screen, the view of the surgical file is satisfactory, and the deflection and flexion of the device were 2. 30-watt laser was used for fragmentation and dusting of the stone. And now the power of the laser was increased. And popcorn effect of laser was used final fragments. You see at the end of the surgery. At the end of the surgery, a 6 Franc WJ stent was inserted. This slide shows the final result of the patient. As you see, there is no residual fragment on the postoperative first day on QUV, and 1 week later, the WJ stent was withdrawn. Thank you for your attention.
Thank you, Dr. Muhammad. The last station will back to Saudi Arabia, Dr. Abdulaziz Al Hadal. He will consultant in urology at King Abdulaziz Medical City in Riyadh. Welcome, Dr. Abdulaziz.
Hello, it's nice to be here. Hello, everybody. I'd like to introduce myself. My name is Abdulaziz Al Hadal, an endourologist based out of National Guard Hospital in Riyadh, Saudi Arabia. And I will be sharing a case using a 7.5 French PUSEN scope. So let's just talk briefly about the patient. He's a 65-year-old man, medically free. He was presented with bilateral flank pain, and CT-KUB showed him to have bilateral renal stones. The first procedure was a left-sided ureteroscopy done around 1 month ago. The problem we faced at that time was that at the first procedure, the ureter could not accommodate the scope, so we had to stent the patient and bring him later on for a full ureteroscopy. So instead of having a procedure in one go, we had to do it in twice because the ureter was very narrow. It could not accommodate the scope itself. So in the second procedure, we were lucky to have a 7.5 French scope in our hands, and we elected to use it in this setting rather than stent the patient and then go ahead and take him later on for a second procedure. So as you can see in this image, the arrow is pointing at his UO, which is quite narrow from the image itself before doing anything else. So this is what we were dealing with in the first time. We saw this UO and we tried our best to manipulate our way into the ureter. We could have dilated the ureter using a semi-rigid scope, but we elect to put a stent in and then come back later on and do the procedure in a much more natural way. And this is the ureteric orifice with the ureteric catheter being inserted into it. As you can see, comparing the size of these two diameters. And in this image, you can see the ureteric catheter being held in my hand, and comparing on the other side, you can see the difference between the size of the ureteric catheter as well as the 7.5 French scope. I think we're using a 6 French ureteric catheter at that time. As you can see, it's a quite small scope with a good imaging. And in this images, you can see the guide wire reaching the upper pole of the right kidney, and the arrow is pointing at the shadow, which is the stone. So it was around a 0.9 centimeter stone. Unfortunately, it was in the pelvis, but I think during manipulation, it was bumped down into the lower pole. And in the other screen, you can see the PUSEN being pushed through the ureter without an access sheath, as we know that most probably the ureter wall will not accommodate an access sheath. And after pushing the scope all the way into the kidney, we can then start our procedure. We typically use 2 wires. One is safety and the other one is working to insert the scope up all the way into the kidney. But some people advocate that the scope itself could be used as a safety guide wire if you're going to be working in the kidney itself. And as you can see, we have a retrograde here showing the anatomy of the kidney, and then in the other image, you see the scope reflected in the lower pole with the shadow of the stone in front of the scope. And this is the setup we usually have in the system in our OR. Having ergonomics is very important to relax your neck, which I am not doing in this image because we were using the monitor to record this video that you will see later on in the presentation. But we usually use the adapter to connect to our own monitors, which gives you a bigger screen. And moving on to the video itself, you can see the quality of the image is quite well. Although this is a small scope, we're pulling back from the the upper pole. We already took a look at the middle calyceal system, and after which we're going to go into the lower pole and identify our stone, which I already mentioned was a 0.9 centimeter stone that was originally in the renal pelvis, but unfortunately it was kicked down into the lower pole. And after going onto the lower pole, we can identify our stones, actually single stone. At the beginning, the image was not very good because this was still having some contrast in the collecting system. But after some irrigation, we were getting a better quality image, as you can see. Now we are taking our 200 micron laser fiber. We're using a 30-watt laser system. And we started with a very low settings, actually, in the beginning, around 0.5 joules and 12 or 15, actually, hertz. I can see the patient, the problem with the moving with the kid with respiration is that the patient had a family history of malignant hyperthermia. So we could not give him GA in fear of him having the same reaction. And we opted to do the case under spinal anesthesia with very high block. The patient tolerated the procedure very well. And as you can see now, we start fragmenting our stone and dusting the stone into very fine dust. As we proceed through the case, we had a little trouble with our irrigation system in the beginning, which we addressed quickly. We had to change the TUI Borst adapter that we usually use. It was leaking. And we used the same adapter that came with the scope, and actually it was quite successful in fragmenting the stone. Keep in mind that this video is fragmented. It's a long procedure, so we took some parts of it and we glued them together to show you an overall picture of what's going on with the patient. And sometimes we just stop to take a look and see what's going on and to do quite some irrigation to see the fragment size that we're having. And so once we assess the fragment sizes, we know that we are doing the proper job that we should be doing at the same time. So we usually start with dusting the stones with the settings that I mentioned, and then at the end of the procedure, as you can see right now, we do some popcorning with high power and high frequency just to finalize everything that we have done. And although the patient does not have an access teeth, at the end of the procedure, as you will see, the fragments were all dusted in a very good way, and most of them were flushed out of the lower pole. As you can see right now, this is the lower pole after we have just concluded the procedure. And we will stent the patient. I'm putting the guide wire back in, making sure that it's in the kidney coiling properly. And then I pull the scope through the ureter just to see what happened to this ureter, which we know is very narrow. And fortunately, everything went smoothly. No problems did occur during this procedure. And we'll put a double J stent in place and keep it for around 2 weeks. We'll do a KUB because the stone was radiopaque, and we'll assess whether or not to remove the double J stent at that time. Thank you very much.
Thank you, Dr. Abdelaziz. I think we reached to the end of this session. It was very interesting to share and experience between different experts from different countries. I think Dr. Saeed and Dr. Wang is still with us in the session, and I need their final conclusion. In 1 minute each, just your conclusion for the 7.5 scope. I want also extend our apology to many questions coming to the platform, but we are short in time. Many comments about the size of the stone. Some colleagues, they are using size of the access sheets, some about the pre-stenting, post-stenting. So still there is difference in practice between based on the experience case by case. Dr. Saeed, Dr. Wang, in 1 minute each, please, your final conclusion and comments, please.
Dr. Saeed, can you open the camera?
I tried to open the camera. You cannot start because the host has stopped it.
We hear you now.
Okay. So I think Dr. Yasser, since the beginning, the vision was the main factor. We used to have the conventional, the digital. The size is very, very important because you can achieve two things. The easier access, you have an access to the kidney more. So you can negotiate with the patient that I have the scope, so I can have more successful to access your kidney. And for the, as all of the speakers I have heard, something very important is the septicemia, the pressure. Everyone was tying the size to the pressure inside the kidney, which is very important in the retrograde interrenal surgery because of the closed system with a small space in the kidney. So the size is coming, the 7.5 or less than that, I believe it's less than that, is coming to stay, is coming to take a very big share from the market. And I'm willing to say that, and I can bet on it that the 7.5 will take a big share of the market.
Thank you, Dr. Saeed. Dr. Wang, your final conclusion and the comment, please.
Thank you very much, Professor Yasser. I just want to thank you very much for your invitement. And it's my great honor can share my experience with so many good friends and very famous colleagues in the worldwide. And I just want to invite all of our colleagues in worldwide, if you have chance, you are very welcome to come to with us in the future. Thank you very much. Thank you very much, Professor Yasser.
Thank you, Dr. Wang. But just final comment before you are leaving. I think with 7.5, the common or the routine use of 12, 14 access sheaths in China, maybe little bit change?
Yeah, I think the development of equipment will change many of our strategy in treating stone disease. Thank you very much.
Okay. Thank you for everyone, and thank you again for PUSEN for supporting this session, and thank you for who joined us virtually and who with us here physically. It was a lovely session. Thank you, and stay safe. Bye-bye.